Thank you all for coming on Public Square to talk about this issue. I want to start with our young people. Talk a little bit about your experience in terms of getting involved with a team-based, with a health center at school. Why did you need help?
Everybody has a past, and I grew up with alcoholic parents. My father was abusive. Thankfully, he's gotten help. I practically raised my 3 younger brothers. I've been in a lot of abusive relationships, and by the time I got into middle school, I was bullied because I didn't have a lot of girls as friends. I chilled with the guys because there was no drama. But a lot of girls, like, I'd get into altercations with them. Middle school is very stressful for me. And at that time, I started seeing a counselor. I was so mad the first time I went to see her, and I accidentally let something slip that I wanted to kill myself. I've tried in 2nd grade, I've tried 4th grade, 5th grade, and again in 6th grade. And by saying that, she evaluated me, and I was sent to UNM's CPC, Children's Psychiatric Center. And I knew I messed up. My parents weren't talking to me. They were shocked, but at the same time pissed off. I had to get out of there because the whole res was talking about it. It's like, oh, a little Native girl went into a net case phase, and I was like, ugh. So I let everything go, pretended everything was fine, and I got released the following week. And 2 weeks later, it happened again. I got evaluated, and I was sent there, and I stayed there for about 9 months. But by the time I got back, I was in 7th grade. Things just got worse. Everybody was calling me the crazy girl and all this other stuff. And it really hurt, especially coming back. And when I came back, I was on medications for depression and for being bipolar, and because I couldn't sleep at night. And by the time I was in 8th grade, I was already getting into drugs and drinking and doing all this other stuff and taking off with my mom and dad's cars and trucks and just not being the best person in the world. By the time I was in 9th grade, they had sent me to Santa Fe Indian School. I felt like I didn't belong there. I dropped out the beginning of my sophomore year. By then, I was homeless. During that time, I got this. This wasn't intentional for me. I didn't want it.
Is that the name of someone you were in a relationship with?
Yes, his name is Aaron. Thankfully, he's in prison right now. But a few people held me down and did that to my neck. And before they did that, they beat me. It was hard. It was terrible. Finally went home, and I started going to school at Laguna Acoma High School. And around then is when I started going into the teen center.
Did you go there on your own? You wanted to find someone to help, or did someone refer you there?
I was referred by a few people. I personally thought that it would be better for me. I didn't want to be that person that I was anymore. After a while, I opened up, and I continued going there throughout my senior year, and I've been advocating since then.
What do you think needs to happen to make it easier for young people to get the help they need?
I think that the students need to know that confidentiality is a must. If you go in there, whatever you say in there stays in there. It doesn't come out. And you shouldn't be judged or labeled for going into a teen center.
Jennifer, you went through a lot of tough experiences. You were raised by a very loving grandfather, but then you also became a victim as a child. Can you talk a little bit about that and what impact it had on you?
I was sexually assaulted by a family member, and it had gone on for quite a few years, and I was scared because when at first I had been screaming for help, and they told me to be quiet, and I thought, well, am I doing something wrong? Maybe I should just keep it to myself. So I did keep it to myself until I was about 13, and then I think that's when my grandpa died right about then. And that I really got depressed then, and I ended up being sent to a different school. Luckily, that's where they had a school-based health center, and that's what brought me out of my depression, and here I am today.
How did you manage to get connected with the school-based health center? Did you go seeking help?
No, I had scars on my arms, and my teachers had seen them, and they sent me to the health center.
Were the scars from injuries inflicted on you?
Yes, I had
you
cut
d-
myself.
Okay. What did you think? Did you want to go?
No, I didn't talk to my counselor for almost a year. We'd sit there in our little sessions, and he'd try and get me to talk, and I'd be like, I'd nod my head, like, can I go back to class? That went on, and then I finally felt comfortable to let him know what had happened. I really was scared to let them know, because I really did think I had done something wrong.
If you hadn't had a school-based health center like that, where else do you think you would have gotten help?
I don't think I would have gotten help.
And how have you been involved in the center throughout these years in high school?
Well, it started as just me seeking therapy, and the more I was able to accept what I had been through, I was able to bring more students in to realize that there is this place that you can go to, and that people do care, and you're not alone no matter what.
James, your organization works with families and young people to navigate systems and get services, and you actually were diagnosed with bipolar when you were quite young.
Mm-hmm.
Were you able to get the help you needed, and is what you went through typical? Is it any way similar to this?
Not as bad as I think that they went through. I was first diagnosed with ADHD, and the bipolar, which I was actually misdiagnosed as. I actually have Asperger's, which is a form of autism. But I was diagnosed with bipolar, which was part of a stigma because my father had bipolar. And he overdosed, which is what took his life when I was about 6 years old. So the stigma from my father got basically labeled onto me. So getting services for what I was diagnosed with also was a challenge. I was lucky enough to be in a really good elementary school that had a lot of in-school services. And I was able to see good counselors at the time as well. But I mainstreamed into regular education because I excelled in math and science. So the stigma of, boy, you're just coming from special ed, we got to look out for you, very much got applied as well. So living through that, I have a lot of the experience and I guess wisdom of what stigmas can be placed on people, and that a lot of people don't fully understand what's going on, especially in schools. And as a youth coordinator, I'm not a therapist. I'm not there to help them with their problems as well. I'm more there to honestly teach them how to be their own advocates. Because when you turn 18, a lot of services get turned off for you. You're not a youth anymore. If you don't know how to self-advocate, it's a lot harder to get those services for yourself. It does help, especially when there's a lot of people who don't understand what's going on, and they do have that stigma.
Dr. Aceves, you run a clinic in the Southeast Heights, and Dr. Adelsheim, you're involved with youth mental health issues, but it seems like these get bifurcated between mental health and primary care, and I know at your clinic you try to be a little more holistic about that. Can you talk a little bit about what you do at the clinic to someone comes in and trying to address a mental health issue for a young person?
What becomes very clear as you get to know the families is that some children come in with problems that really have an underlying behavioral health or mental health issue. And it takes a time, it takes a little bit of deliberate effort to identify those conditions. And so it was very clear in that population that we needed to take the time to address them and to make some structural changes to incorporate behavioral health services into our practice.
That is an area we work on quite a bit, and I think there are two pieces of it. One is there a way in which is built into the way you're practicing where you're asking the questions? And we do have some evidence-based screening tools that ask questions about substance abuse and depression and anxiety and risk for suicide. And those are kind of, I think, the major topics you want to try to get at. But that if you structure those into the pediatric practice so that when you're doing a well child check, you ask those questions in sort of a structured way, then you're more able to get at kids who have issues and problems early.
What kind of questions do you think in that context should be asked?
You know, specific questions about anxiety, specific questions about depression, specific questions about substance abuse. You know, substance use is a huge issue for adolescents in our state, but as doctors, as pediatricians, we frequently kind of gloss by some of that. We make the assumption that if you're in school and you come in and you're looking okay and you're there with your mom, that everything's probably going fine. And it's hard to ask the question of a fresh-faced 12 or 13-year-old, you know, what kind of substances might you have been using, and have you had sexual intercourse, and do you ever think about hurting yourself or others, or have you ever tried to kill yourself?
I see Peggy nodding. How common is that? How common does that come up in school-based health centers or in pediatric?
Well, I think it's very common in school-based health centers. Someone comes in for a stomach ache, you know, so it seems a simple thing, but, you know, once the school nurse starts to ask the questions around that, you know, there's more questions that are underlying. But exactly what else is going on? What's more than the physical complaint that I'm hearing now? And so they're asking similar questions and following it through, and then they also would be referring to the counselor or beyond that. So it's never as simple, as I want to say, as just the event that occurs when somebody comes in. But there's always a piece to it, so you have to keep looking for that piece, and it's very common.
I mean, do schools have the capacity when this comes to the school nurse? Are they trained well enough? Do they know enough to?
I'm sorry, I should laugh.
Go ahead.
Are you kidding? No.
Go ahead, Linda.
There are screening tools, and we've certainly used some. But kind of like what you were saying, really the presenting problem is rarely the issue.
You're not going to come in and say, I'm depressed, right? Would you guys go? Maybe you
yeah,
would.
Some kids,
you think that's common?
Some kids might, but you know, I mean,
Okay.
you'll see the behavioral issues. You'll see the drinking, the partying, the cutting, and all those things. And usually it should be a red flag, but that's not the reason. I mean, the reason somebody does something is the underlying issue.
Now, you don't have a school-based health center, right?
No.
In Rio Rancho. So what is in place that
We
might
do have
be-
therapists that come on campus, but you kind of end up with a double-edged sword in the respect that sometimes the kids who need the most help are also the ones that are failing. So the end result is that when you're a school and you have to produce and all the new things that are coming along, if we don't have them graduated also, then it's a conflict of two different things.
I mean, the school's focused on, like, let's just get these
Right.
graduation rates up.
Well, or just we want them to graduate. We want them to be successful by the time they get there. And there are a lot of different issues that really prevent kids from doing well. It's a tough one because you want to support the kid, but you're not always able to. We do the processes, but they're also one person for somewhere between 700 and 1,500 kids. So how can one person really provide for that?
Steve, can you give us an idea of what kinds of screening take place now for kids and how young it starts? Should it be starting younger?
As we all know, half of all mental illnesses have their onset by the age of 14. And at the same time, 1 in 5 kids may have a mental health issue at any point in time. And I think what we're hearing is around some of the specialized programs or some of the supports we have in place, and as Dr. McGrath was talking about, we have some of those screening programs in place within our school-based systems. But I think what we're also talking about is how do we build them more effectively into, for example, Javier's clinics, even with children at a very young age. And as we look at our state, you know, where there is certainly interest in building home visiting programs and very early support for new moms and young kids and their families, how do we build those kinds of early supports in to ensure that attachment is strong, that parents have the skills they need to be effective parents and raise their children quite well. Right now, we don't have many of those structures in our state system. When we look at the screening tools, even under our Medicaid system, you know, we don't have the behavioral health questions that go with the physical health questions. And while we talk about parity as a nation, we really still don't see it in terms of equity of resources, equity of identification, and we have a long way to go. You know, you were asking about stigma to some of the folks here, and I think what's very clear is we all have mental illness in our families. We don't talk about it. And as a result, advocacy becomes harder. It gets more difficult to get the resources that we need. And I think we all really have an obligation to have the courage of the young people here and many others to be able to speak more directly about these issues so we can build these resources, because we're underfunded, we don't have the supports in place that we need, and while these are great programs we're talking about, we don't have enough of them.
Javier, in your clinic, how do you kind of broach an issue with parents? If they have a young child, you might see some kind of underlying trauma or mental health. That can be very touchy, right? Versus talking about a sore throat.
Correct.
How do you have that conversation?
We need to be able to have those open-ended questions. And how are you doing? And how's family life? And it must be difficult to have a couple of teenagers at home or toddlers, and just wait for the answer. And that usually guides the conversation. I think that the emphasis still is in our health system in addressing just acute care. And the system supports that it's, you come in with a problem, let's fix the problem, move on.
I sense from hearing from the schools, what I've heard from you too, is that the schools are under similar kinds of pressures that, you know, we need to get graduations up, rate up, we need to do this, we need to do that. Doesn't necessarily leave room for the needs of people who might need to go to the school-based health centers, right? You're saying, I think I heard you say that sometimes there's some tension between administration and...
Yeah, like the tension's there, and like you have to walk through the office in order to get to our school-based health center. It's like pretty much dead man walking. As soon as you walk down that hallway, judgment, administrators just staring at you. You have to pass by their offices, and you can see as soon as like you walk by, they're looking right at you. And like you feel like a freaking deer in headlights, literally. And as soon as you get into the school-based health center, it's like, oh my gosh, can't believe I made it. And sometimes they won't let you in because, well, sometimes your teachers won't release you because you're in your core classes. And that's completely understandable. Students need to be in their core classes. So they made an agreement trying to meet halfway. Okay, we'll only take you out of elective classes. But guess what? We only have 2 caseworkers. Their loads are unbelievable. But when they take you out of your elective courses, you don't do so good in your elective courses. So it's like you can't find common ground anywhere.
I would like to just address the scheduling issue. That's a real issue because, you know, taking a student out of one class every week, the grades do go down. So we have this dance we do, and we move it around, and we do the best we can. I always try to keep in mind, if that student was seeking services somewhere else, they would be gone for half a day or a day as opposed to that 1 hour.
Because the center is there.
It's on site. Absolutely. So I see that as a real benefit, that if we really want students to access services, doing it at the school-based health center is the most efficient way to do it, and it keeps you in school.
Jay, how do you balance these things as the administrator?
I don't know who uses the health center. I don't have that information. I don't want to know that information. I just want to know that those services are available to students. You don't have to run the gauntlet, for example, to go to the Mustang Health Center. It's a different kind of experience. It's separate from the office. We made a very deliberate attempt in Mountain Air to really bring all of the people together that are involved, whether it's the school nurse, ancillary staff, school psychologist, social worker, and really sort of have a cohesive team. And so I don't think that some of our students face the same challenges. I think that there's less stigma in going now. The trust has developed over the years. I can tell you that by October of every year, the need for behavioral health exceeds the capacity. And so, you know, that's typical of school-based health centers.
There was a pretty steep learning curve in the
Okay.
beginning where I think staff, when they referred a student to the health center, expected us to report back.
Right.
And so very quickly we all learned what the boundaries were going to be, but there was a trust that needed to develop with the teachers too and the administration with us, that we were going to take care of things. No, they were not going to be a part of that, knowing what was going on. When students come, we say, if anything leaves here in the way of information, it will not be from us.
As we start going to the next part of the show, I just want to ask Steve, I know you recently have been in the news. You guys have a new kind of early intervention program at UNM. And is this part of the ecosystem? Is the school-based centers, or is it larger than that?
So as I started working in school-based health centers many years ago, our focus was really on sort of helping identify the young people with those early warning signs that might not be as obvious. The quiet, withdrawn, avoidant students sitting in the back of the classroom, and then they're not even there. And so how do we find those kids, as Dr. McGrath mentioned, who might be more depressed, might be more anxious, might have other issues? And I think over time, what I started learning about was also those young people who might also be experiencing a serious psychiatric issue, who might start hearing voices, who might be starting to get confused, who might be starting to wonder if their brain is playing tricks on them. We can see young people with serious psychiatric conditions having great success when we can wrap supports around them and their family, deal with the anxiety around those issues, help kind of lower some of the stress levels, and see great outcomes for young people, for their families. And school is, an important place for identifying those issues, maybe not the place where all the intervention always needs to happen.
Well, we're going to bring in a couple of our folks from the state, and we'll continue this conversation in a minute.